shifting gears now and moving to regenerative therapy in heart failure. This is a heart failure session, and I call Dr. Bartunek to present the data of the CHART-1 trial to you.
Good morning. Thank you very much. Good morning, ladies and gentlemen. It's a pleasure to brief you on the outcomes of the CHART-1 trial. So why this trial? Well, we all know that advanced ischemic heart failure with cardiac enlargement leads to poor outcomes. There's a still unmet clinical need. In this regard, cell therapy is a new paradigm-shifting intervention that targets organ restoration. Cardiopoietic cells derived by lineage specification of patients' own mesenchymal stem cells showed clinical promise as a next-generation therapy. So our objective was to validate the efficacy and safety of cardiopoietic cells derived and delivered endomyocardially via retention-enhanced delivery catheter in advanced ischemic heart failure. How we did it? Well, it was a prospective, multi-center, randomized, sham-controlled, patient and evaluator blinded study performed in 39 hospitals, Europe and Israel. We included patients with advanced ischemic heart failure on standard of care, randomized to two groups, one active, receiving endomyocardial cell therapy, a second group, control group, undergoing a sham procedure. Cell delivery was performed using a retention-enhanced delivery catheter, and the primary endpoint was a Finkelstein-Schulfeld hierarchical composite, where in fact each patient is compared to every other patient with respect to hierarchical analysis of all-cause mortality, worsening of heart failure events, quality of life, physical fitness, and changes in cardiac structure. Using clinically meaningful cutoff values, we derived a sample size of 120 patients per group to reach the 87% power for Mann-Whitney estimator. There's an estimate of probability of better outcome to reach 0.61. I remind the values of above 0.5 favors the treatment. This is the key finding. The primary outcome in the overstudied patients was neutral. Mann-Whitney estimator was 0.54, though favoring the active treatment that did not reach statistical significance. Cardiopoietic treatment through 39 weeks was safe, and we observed lower incidence of sudden death and abortive sudden death in the active group as compared to controls. After this, we performed two exploratory analyses. One looking at the modifying effect of the baseline markers of heart failure severity. Among several of them, the most apparent benefit has been appeared from the baseline diastolic effect, baseline diastolic volume. In other words, in patients with baseline diastolic volume between 200 and 370 milliliters, the probability of outcome was better in active as compared to controls, with Mann-Whitney estimator reaching 0.61, suggesting a benefit of a therapy when therapy is applied in the well-defined cardiac enlargement. This benefit was driven by consistent trends in mortality, worsening heart failure events, quality of life, similar walk distance, and in parallel with high degree of improving in cardiac structure. Other analysis looked at the modifying effect of treatment intensity. That means how many injections we performed. And we have found that in patients with 19 injections or less, again, a probability of better outcome was higher as compared to those receiving higher number of injections. By combining now both elements, targeting patients with optimal cardiac enlargement, with optimal intensity, the probability of outcome was further increased with a significant reduction of clinical endpoints, quality of life, and physical fitness. So what are the key learnings from the study? Our study is the largest clinical trial testing cardiopoietic cells in advanced ischemic heart failure, successfully conducted in a multi-site, multinational setting. The primary efficacy endpoint was neutral in the entire trial population. Nevertheless, exploratory analysis suggested a benefit of cell therapy in a large subset of patients defined by degree of left ventricular dilation, driven by consistent trends on clinical endpoints, quality of life and physical fitness. Of note also, the treatment intensity with lower number of injections may potentiate outcome. So the main clinical insight to take forward is that optimized treatment intensity, together with disease severity targeted patient selection, should be considered for future trials of clinical cell therapy in heart failure. Thank you very much.
Yeah, well, thank you. So that's, I think as a caution note, it should be congratulated for a large trial, but although it was neutral on the outcome, that at one point we have to make the point, we shouldn't get carried away with exploratory analysis, secondary analysis in a trial that was neutral on the primary. So that's as a general rule when we interpret trials, but we all know that. Okay, questions?
I guess I would have one question while the members of the press are thinking about this. So please explain how lower number of injections is better than higher number of injections. That's not immediately intuitive.
Not really.
That's a good point. Indeed, we have to be aware of one fact, that unlike in the classical drug therapy, we are not dealing with the chemical compound, we are dealing with the living cells. But the potency of the cells, it's hard to predict upfront. It's one thing. Second, there are a number of other elements that determine the potential efficacy, and that means the applicability of number of injections within a given target myocardium, where we have segments that they are not basically reachable and targetable. And also what we are seeing across the studies that are available, were a very varying effect as regards to dose dependency. It was not yet demonstrated. You have studies that are showing some degree of dependency, whereas many patients with ischemic heart failure or in the chronic myocardial ischemia, studies suggesting or appear to suggest that maybe the lower number of injections could potentiate the efficacy better than the higher number of injections. And we can speculate about the potential other explanations, the number of injections, the loading of myocardium with the cells, injury eventually that you impose by that. Though in these studies that we are seeing, the minimal rise in troponins is noted. So it's a comprehensive issue. And I have to acknowledge also the fact that our study was not designed to find a dose dependency. We had a range of injections that in fact went from 4 to 21, in fact, and with a sizable number of patients with injection 19 and higher, and by taking the median value, that's what basically came out of it. But again, I think it's too premature to make a strong statement. What is the exact mechanisms underlying that?
Other questions? Yeah.
Lynn Peterson with Trends in Medicine, and I apologize if I mispronounce your name, Dr. Schutzke. Did you not just contradict yourself when saying you wouldn't put the emphasis on a subgroup analysis in this trial, but you did in another trial? You did in the Danish.
No, I didn't say that. Not at all. I just said as a cautionary note in general, if a trial is neutral, as we all know here in the room, on the primary, that we should be careful with putting too much weight and getting carried away in on a subgroup analysis. I didn't do that at the Danish. The Danish was neutral. We can go on that on the primary, and we all have to exercise caution in looking into any subgroup analysis of a trial that's neutral. That is true for Danish. That's also true for this trial. We are consistent in our message here.
If I may say, I think it's clearly neutral. We acknowledge that. But also it's important to recognize the fact that it's a new field that's evolving. There is not so much known about how this therapy should be applied. And I think it's very important for the field, for further development, these particular subset of patients, to really take the signals along forward and to apply them in the well-designed and properly powered studies to address the specific signals that were generated by this study.
Final question, please. We can't hear you.
Janet Fricker, Congress News. Could you explain how the tension-enhanced injection catheter worked and how that influenced the number of injections you actually gave?
Well, as I mentioned in response to Dr. Jozef, it's an intriguing finding that we found, and It's something that we have to address further, but it's clear that we see that in those receiving 19 or less, I will just tell you, we see very marked reduction in asystolic volumes, which is much more pronounced as compared to those receiving number of 19 and more injections. So the strategy, and that's how we do that, is that you have a certain guidance. You guide your procedure by deciding about the volume of injection and by deciding the spots of injections. And in that context, the optimization regarding the number, it seems to be something to be further tested, yeah?
So we need to move on. Thank you. Thank you very much.